Hello everyone, welcome to the Journal Club presentation of NPT India. I am Farah, PhD scholar from the Department of Physiotherapy, Manipal College of Health Professions, Mahi, Manipal. Today I will be presenting a Journal Club session on the TWIST tool, which is an evidence-based clinical prediction model that estimates when patients will recover independent walking after stroke, published in Neurorehabilitation and Neural Repair in 2022. This work was done by Smith et al. From the University of Auckland, New Zealand. Independent walking is one of the most important functional outcomes after stroke, both for patients and clinicians. Early prediction of walking recovery is crucial because it influences rehabilitation goals, therapy intensity, and most importantly, discharge planning. However, many existing prediction studies produce regression equations that predict independent walking at a single time point of 6 months post-stroke or discharge from the hospital. Although predicting walking ability at discharge from the hospital is also problematic because discharge decisions are based on cultural factors and local health services in addition to the walking ability. Therefore, a tool that predicts not only whether but also when a patient will walk independently is clinically valuable. So in an exploratory study in 2017, the same authors found that trunk control and hip extensor strength at 1 week post-stroke were the most important predictors for whether a patient will walk independently by 6 or 12 weeks or remain dependent at 12 weeks post-stroke. While early findings of this study were promising, the sample size was too small as 41 participants. Data were collected from a single study site and 2 outcome time points were evaluated. These limitations motivated the development of a more robust and generalizable tool, which led to the updated 2022 TWIST prediction tool. The aim of the present study was to build upon earlier work by expanding the range of potential clinical predictors, recruiting from additional hospitals, and increasing the number of walking outcome time points. The objective was to develop and internally validate a clinically practical tool capable of predicting whether and when independent walking would be achieved within the first 26 weeks following the stroke. This prospective observational study included adults aged 18 years or older who had experienced a new ischemic or hemorrhagic stroke within the previous 3 days. Individuals were included if they demonstrated new lower limb muscle weakness below 5 on the MRC scale and were unable to walk independently, defined as a functional ambulation category score of less than 4. Patients with recurrent stroke were included if the previous event left no residual lower limb weakness. As exclusions, cerebellar or bilateral stroke, pre-stroke use of a walking frame, pre-stroke FAC less than 4, significant communication or cognition deficit, or any medical instability was excluded. Clinical and demographic data were collected between days 3 and 5 post-stroke, including NIHSS and FAC. At 1 week, detailed lower limb assessments were performed, such as Fugl-Mayer assessment for the lower limb, MRC muscle strength of hip abduction, flexion and extension, knee flexion and extension, ankle dorsiflexion and plantar flexion, trunk control test, Berg balance scale, motricity index, visuospatial neglect using the star cancellation test, and sensory assessment using the monofilaments. Walking ability using the functional ambulation category was reassessed at 2nd, 4th, 6th, 9th, 12th, 16th, 20th and 26th week post-stroke. Independent walking was defined as functional ambulation category more than and equal to 4. These repeated time point assessments allowed the researcher to identify precisely when each participant achieved the independent ambulation. The study also quantified inpatient therapy exposure. Therapists recorded the number of minutes of active lower limb, trunk, gait and balance training delivered during inpatient care. Therapy dose was the total duration of active lower limb therapy, while therapy intensity reflected average minutes per therapy day. These variables were collected to describe the cohort but were not included as predictors as they are not available at 1 week post-stroke when twist is designed to be used. Study flow chart explains how participants moved through the study. Initially, 106 participants were consented between day 3 and day 5 post-stroke. At 1 week post-stroke, 100 participants still had a functional ambulation category score of less than 4 and were therefore enrolled in the study. During follow-up, 7 participants were excluded from the final analysis because some experienced a second stroke or another significant medical event affecting their walking ability. Some died before achieving the independent walking and some were lost to follow-up. So finally, 93 participants were included in the final analysis. Walking recovery was categorized based on whether participants achieved independent walking at predefined time points as mentioned here. Time points with less than 10 participants were combined with subsequent ones, resulting in the final 5 analysis time points as 4th, 6th, 9th, 16th and 26th week post-stroke. For the variable selection, following guidelines for prediction modeling and ensuring a minimum of 10 events per variable, 7 clinically relevant predictors were selected for the model development as age, MRC grade for hip flexion, knee extension and ankle dorsiflexion, trunk control test, Berg balance test and the presence or absence of visuospatial neglect. These predictors were based on established predictors in previous literature, commonly used in clinical care and ease of use in known ambulatory patients. For the model development, backward stepwise Cox regression was used to determine significant predictors. After controlling for covariates, 4 predictors remained the significant as age, knee extension, MRC grade, Berg balance test, and the presence or absence of visuospatial neglect. Then Cox multivariate regression analysis was conducted and these variables were then converted into the categorical variable using the defined cutoff values. Based on the beta coefficient, each variable was assigned a score of 0 or 1 and for the Berg balance test 0, 1 or 2 was assigned. The scores were combined to obtain the final twist score for each participant at the end. Model internal validation was assessed using binary logistic regression with bootstrapping with 1000 samples and 95% confidence interval. Calibration was evaluated using calibration plots and the Hosmer-Lemshow test, while discrimination was assessed using ROC curve and C-stats. Based on predicted probabilities, twist scores were grouped into 3 likelihood categories for achieving independent walking as unlikely, possible and likely. Moving on to the result, out of 100 recruited participants, 93 were included in the final analysis as I mentioned earlier. 57 participants achieved independent walking by 9 weeks, 18 achieved it between 9 and 26 weeks and 18 did not achieve independent walking by 26 weeks. As lesser than 10 participants achieved independent walking at each of 2nd, 12th, 16th, 20th and 26th weeks post-stroke. So participants at these time points were combined with those who achieved independently walking at next time points until at least 10 were in that group. The final twist analysis then focused on the selected time points of 4th, 6th, 9th, 16th and 26th week. This table shows the distribution of participants achieving independent walking across different post-stroke time points, demonstrating that recovery does not occur uniformly. A larger proportion of participants achieve independent walking earlier, while a smaller but clinically important group recovered later. The table summarizes baseline characteristics and outcome distributions, helping to compare those who achieved independent walking early, late or not at all by 26 week. Overall, this table highlights the heterogeneity of walking recovery after the stroke. So the final outcome of the model development as reported in the article, when all 7 candidate variables were entered into the Cox proportional hazard regression model, four variables only remained the significant predictors of time to independent walking as age, knee extension, muscle strength, work balance test, and visuospatial neglect. The authors report that higher knee extension strength and higher work balance scores were associated with a greater likelihood of achieving independent walking earlier, whereas increasing age and the presence of visuospatial neglect were associated with delayed or reduced likelihood of recovery. Importantly, trunk control, hip flexion strength, and ankle dorsiflexion strength did not retain significance once these four variables were included, suggesting that their predictive effect was mediated through balance and knee extension strength. This reinforced the central role of balance, anti-gravity strength, and perceptual function in post-stroke walking recovery. Table 2 shows the final predictors retained in the multivariate Cox regression model at 1 week post-stroke. Only three variables remained significant as age, knee extension strength, and balance ability. Patients younger than 80 years had a higher likelihood of achieving independent walking and were assigned 1 point. Similarly, knee extensor strength of at least MRC grade 3 contributed 1 point, highlighting the importance of anti-gravity knee control for gait recovery. Balance was assessed using the work balance test, which carried the greatest weight in the model. A score below 6 received no points, scores between 6 and 15 received 1 point, and scores 16 or above received 2 points, reflecting progressively better postural control and earlier walking recovery. The second table summarizes how these components are combined to calculate the twist score, which ranges from 0 to 4 points. This total score is then used to predict the probability and timing of independent walking recovery at 4th, 6th, 9th, 16th, or 26th weeks post-stroke. Overall, the twist tool relies on simple bedside assessments that can be performed at 1 week post-stroke and provide clinically meaningful time-bound prediction for the walking recovery. Model performance was assessed using the binary logistic regression with bootstrapping, as I mentioned earlier, to ensure the robustness of the result. Calibration of the model was evaluated using the calibration plot and Hosmer-Lemshow test. Across all time points, the Hosmer-Lemshow test was non-significant, indicating good agreement between predicted and observed outcomes. Discrimination ability was assessed using the ROC curve analysis, reported as the C-stats. The C-stats ranged from 0.87 to 0.94, demonstrating the excellent discriminative ability of the twist score in predicting the independent walking. Overall model accuracy was consistently high, ranging from 83% to 86% across all post-stroke time points. This figure illustrates the probability of achieving independent walking for each twist score across different time points. The probabilities are color coded into three clusters: red, orange, and green. Red indicates patients unlikely to achieve independent walking, orange indicates a possible chance to achieve independent walking, and green indicates patients are likely to achieve independent walking. As the twist score increases from 0 to 4, there is a clear shift from red to green, as you can see in the figure, showing both higher probability and earlier recovery of independent walking. So the twist prediction tool is the first tool providing time-bound prediction for independent walking at multiple early and late post-stroke intervals as 4th, 6th, 9th, 16th, or 26th week post-stroke. It offers practical value for rehabilitation planning, allowing clinicians to set realistic expectations with patients and caregivers also. Table 4 provides a suggested interpretation of the twist tool, which may be a useful starting point for clinicians when planning their conversations with patients and families. Authors have also emphasized that twist only predicts the recovery of independent walking, not overall stroke recovery. Patients who are unlikely to achieve independent walking can still achieve many important functional goals such as bed mobility, sitting balance, transfers, toileting, and walking short distances with assistance. So providing rehabilitation to help patients achieve these goals can have a larger impact on independence, quality of life, discharge destination, and the level of support required to the patient. The Twist prediction tool has several strengths. The clinical assessments are routine, quick to administer, and can be completed at bedside at 1 week post-stroke by a range of qualified health professionals. And the Twist tool also has a clear and accessible format that allows clinicians to combine the scores from each assessment and make a prediction for an individual patient. These strengths support the future translation of this tool into the clinical practice. As any other study, this tool also has some limitations, as a relatively small sample size with only 5 participants achieving the independent walking between 16 and 26 weeks. This is reflected in the lower specificity and negative predictive value at 26 weeks post-stroke. And pre and post-stroke cognitive impairment may influence engagement in the rehabilitation and subsequent walking recovery, but cognition was not assessed in this study. People who used a walking frame before the stroke or who had a cerebellar stroke were not included in the study, meaning that twist cannot be used for these type of patients. The time frame was limited to 26 weeks, and it is possible that some participants subsequently achieved independent walking after this time. Most importantly, twist tool has not yet been externally validated. This means it is not yet ready for use in the clinical practice. In conclusion, the twist tool accurately predicts whether and when patients will regain independent walking at 4th, 6th, 9th, 16th or 26 weeks post-stroke. With simple 1 week bedside assessment, twist has the potential to significantly enhance the rehabilitation planning and patient counseling once externally validated. This presentation is based primarily on the 2022 article by Smith et al., as I mentioned earlier, along with their exploratory work done in 2017 as a twist algorithm. Thank you for your attention. If you have any questions later or would like to discuss this further, you can reach me at the mentioned email IDs. I hope this presentation will be beneficial and highlight the clinical value of prediction models such as the twist tool in guiding time-specific stroke rehabilitation. Thank you very much.